So without further ado, I'm going to turn this over to Dr. Moreau, our guest speaker today. He's actually been with us before, I think last year sometime. Excellent resource in questions such as the one we're talking about today, which is Alzheimer's and a different twist on it. Well, how do you avoid it? Good question. So Dr. Moreau, I'm going to turn that over to you. It's your show from now on. If you need something, just raise your hand or let us know, and one of us will be able to step in and help you out. Otherwise, over to you. Merci beaucoup.
Merci. Thank you.
Your screen is good, Dr. Moreau.
Okay, good. Well, good afternoon, everybody. I'm very happy to be with you. I'm Dr. Moreau. I'm with Anne-Sophie. Anne-Sophie is a rater working at the memory clinic, and she will be talking about 3/4 down the way about her work and what she does exactly and how she does it. And I will be presenting the main part of the conference. I've been in practice 43 years, and I've worked for about 40 years with patients with cognitive disorders. I graduated from the Ottawa U, and I have a specialty in family medicine. So I did hospital work for many, many years, a busy office. And I've been working for the past 12 years in senior citizens home and also at the memory clinic in both Ottawa and Gatineau for the past 2 years. And I've been doing these presentations for the past year. And before, I've given about 700 presentations to pre-retirees of the government about healthy aging and how to take good care of yourself. So this is essentially what I've done. Before I start, I need to say that I have one conflict of interest, and it's obvious. I do work for the memory clinic, so I'm at the right place to learn things. But obviously, I cannot keep silent the fact that I work for a memory clinic, and we'll be talking about Alzheimer's disease. We will have questions that you may be asking at the end. And if you have questions, you may chat the questions. And Anne-Sophie with me, who's well aware of the presentations and has been with me for quite a long time, will be answering the questions. And if it needs to be done verbally, we'll do it at the end. So on this, I will be starting, and I would like to thank the association for inviting us to present, and thanking you also for your time. So today, Alzheimer's disease, and we'll be talking then not only about Alzheimer, but also about dementia. So what is Alzheimer and what is dementia? Knowing that Alzheimer is one type of dementia, so it's not all types of dementias that are Alzheimer, but Alzheimer, that is one type of dementia. We'll be talking about then Alzheimer diagnosis, the prevention, the good lifestyle, good eating habits, and we'll be talking about treatment. And at the end, we'll be talking about the memory clinic, and we'll be ready to answer your questions after. So what is Alzheimer's disease? It's a type of neurodegenerative disease. So cells in the brain are aging, not functioning properly, and eventually they die. There's a big notion that I would like you to grasp right away. When we talk about Alzheimer's disease, heart disease, liver disease, kidney disease, and so on, we're talking about the same basal disease, it's aging of the cells and the death of these cells. So the more we invest in ourselves, the more we take care of ourselves, eat properly, move, exercise, treat the predisposing factors by not smoking, taking care of the cholesterol, the sugar, and so on, the more it will have an impact on delaying the aging of these cells. And by doing so, you will not necessarily be living 20 years longer, but you will find that the quality of life will remain for a longer period, and what we call the morbidity period will be decreased. So this is the major goal, is to take care of ourselves so that we live not only longer, but even more that we have a better quality of life. So that being said, I will review a few cases of dementia that you are certainly aware of, that you know about, and we'll take it from there, knowing that when do we differentiate between just a mild cognitive disorder or what is dementia is quite easy. It's when people are not able anymore to carry on with their daily activities in the house, that then we start to talk about dementia. And what we mean by that is maybe getting dressed, hygiene, personal hygiene, doing the dishes, preparing meals, cleaning the house, the apartment. When they cannot do that anymore, then we can start to talk about dementia. But before that, it's an MCI, mild cognitive impairment, that we can talk about. In Alzheimer's disease, and I will review that later on, we are talking about the accumulation of types of proteins. And we know that these proteins accumulate or start to accumulate up to 20 years before we develop any symptom. So even if we're okay now, we're functioning completely normally, it doesn't mean that in our brain everything is clear. So investing in ourselves again, it is so important. So Parkinson's disease. Parkinson's disease is a common problem that we see. The average age for a start is around 47 years old. And Parkinson's disease will present with mainly muscular problems, with instability, muscle weakness, trembling, unintentional trembling, and may at the end be involved with dementia. It is due to the accumulation of a special body that we call Lewy's body in the cells of the substantia nigra, a very small part of the brain, having to do with dopamine neuroreceptor metabolism. In Parkinson's disease, about 30% will develop a dementia, but down the road, so many years after it has started. In Lewy body dementia, as you can see on the right, that's quite similar to the Parkinson's disease, but the Lewy body that we see in the cells, which are small particles inside the cells, are accumulating in the cortex. So accumulating in the outside surface of the brain where we do the thinking. And this is why in Lewy body dementia, we see cognitive symptoms appearing much faster than in Parkinson's disease, and usually within 1 year. But it may present more or less the same way. And both Parkinson's disease and Lewy body dementia are more clinical diagnosis, remembering that Lewy body dementia will often present with visual hallucinations. Huntington's disease is a autoimmune, not autoimmune, but autosomal dominant genetic disease transmitted to children. The difficult part of Huntington's disease is that people usually have had the time to have children before the disease starts. So they have the disease, they don't know about it, and they can transmit it to their children before having any symptom. And it may present trouble with the morale, anxiety, depression, confusion, memory loss, aggressivity, and muscular also rigidity, and the chorea, which are sudden jerks that they present without any particular reason. Vascular dementia is a disease in which there is a sudden change in the cognitive status of the patients. In Alzheimer's disease, it's very, very progressive. It may take years. In vascular dementia, the patient will have, for example, a big stroke. So was well yesterday, but upon getting up in the morning, cannot walk anymore, or is completely confused. Or it may present through several very small strokes that we see commonly with hypertension. And these very, very, very small strokes accumulate and accumulate until a deficit becomes evident. Not affecting memory as much, so we may miss it at the beginning. But vascular dementia is the second most common type of dementia after Alzheimer. Frontotemporal dementia is also called Pick's disease. It's associated with involvement and local degeneration of cells in the frontal lobe and in the temporal lobes. Frontal lobe means personality. So these people will have a personality that is changing, they're getting confused, they may get aggressive, they don't understand what's going on. And we've had somebody that we all know recently who's been diagnosed with this, with Bruce Willis. This is what he has, a frontotemporal dementia. Mixed dementia means that it is a mix of two types of dementias, and the most common combination is Alzheimer's disease with vascular dementia. So somebody having an underlying process of Alzheimer's disease, perhaps not evident as such, then having a stroke or mini strokes, and then the deficit becomes more evident, and this is called a mixed dementia. Korsakoff syndrome is a syndrome coming from overdrinking alcohol with a persistent deficiency of thiamine, so vitamin B1, because unfortunately, alcoholics do not eat well, and they will be missing that special thiamine vitamin. And if it's not corrected at the beginning, may produce a permanent cognitive state where people are confused and are not able to function independently. And they may present with also rigidity, difficulties to walk, diminished coordination also, and memory deficit. And there's also a pseudo-dementia. A pseudo-dementia is, we think it's a dementia, but it isn't. For example, somebody developing a delirium, which may happen with alcohol, but it may also happen with medications that were maybe prescribed by the doctor. Something given for the bladder, not necessarily an antibiotic, but something given to calm down the bladder from emptying too often. It may be associated with pills for the high blood pressure, pills for the stomach, and we should always review the list of medication when we see there's been a change that seems to be quite sudden. Medication prescribed or medications over the counter, like Suminex or Gravol to help for the nights to sleep, may be involved also with confusion. You remove the medication, you change it for a more appropriate one, and you may realize that the confusion is slowly diminishing, eventually will go away. Same thing with depression. It may be seen, we think it's a dementia, we treat it, and it does improve. So I just went through a few of these dementias, always remembering that Alzheimer is the most common one, and also it's a very, very progressive disease. So from the age of 65, the risk of developing Alzheimer's disease will double every 5 years. From the age of 65, 1 in 10 people will roughly have Alzheimer's disease in Canada. And at the age of 85, we're up to 1 in 3 people. The risk is higher in women to develop Alzheimer's disease compared to men. And the reason, 2 women for 1 man, the reason being that women live longer. So we know it's a major predisposing factor. So women will live roughly 4 more years than men in Quebec. So men roughly 80.5 years and women 84.5. It's quite a big difference. And if you are asking yourself how many Canadians are above the age of 65 in Canada, it's roughly 7 million. And the number of cases is constantly increasing. So we'll see a sharp rise in the next years from Alzheimer's disease. So as we said, Alzheimer is the most common form of neurodegenerative disorders, up to 80% depending on the studies. Dementia is affecting more than 402,000 seniors, and 76 new cases of Alzheimer's disease every year in Canada. So as we mentioned before, dementia is a general term for a decline of the mental abilities severe enough to interfere with the daily life activities. So how will it present? Well, it may present with gradual memory loss that sometimes the patient doesn't even notice, reasoning and judgment difficulties, making sometimes decisions difficult and sometimes inappropriate, disorientation in time, in person, in places, learning difficulties. So even reading, patients may not remember what they've been reading. Loss of linguistic abilities, so difficulties finding words, difficulties putting words together. They know what they want to say, they cannot say it. Sometimes the sentences don't make any sense, but at the beginning, it's mainly a loss of vocabulary and always searching for the appropriate words. Behavioral and psychological changes may be seen also. This is seen especially with anxiety that is showing up, because at some point people are feeling there's something wrong and they don't know what to do about it. It may present also with the depression, and when it's really severe, even with psychosis, just making confusion even worse. And as we said, it is bringing a decreased ability to perform daily tasks. So the physical consequences of Alzheimer's disease may cause loss of appetite that we often see. So a lady in her 60s having lost 20 pounds without any reason since last year, there's something going on, and definitely if it's not voluntary, we would be looking at the cause of this loss of weight. When people are losing weight, usually it's because they don't eat properly. And what is the first thing to go is the protein. So they don't eat as much protein as before. And when they don't eat enough protein, we lose our muscles. That is called sarcopenia. And when we lose our muscles, we're losing the muscles everywhere. And it may predispose to lack of coordination, to lack of equilibrium, and falls. And when we say fall, we're talking about broken bones and also maybe sometimes added head trauma. I will just mention at what age we start to lose our muscles. We tend to start to lose our muscles at the age of 25 years of age. So we lose between 0.5 to 1% of our muscles every year, starting at the age of 25. So you can imagine by 75, there's a lot that will be gone. People also with Alzheimer's disease have a fragility at the level of the small arteries of the brain, and they tend to have more commonly cerebral hemorrhages. Not only do they have a higher tendency, but very often for cardiac purposes, they will be prescribed anticoagulants and antiplatelet like aspirin to prevent the formation of clots. But yes, it may prevent the formation of clots, but it may also increase the likelihood of having hemorrhages. We need to be very careful and outweigh and make sure that which is the most important, the short term, the long term. If the patient has only a few months to go, well, we need to rethink our approach. And as we mentioned before, falls also pertaining to older people, well, they tend to have osteopenia, which is a lack of calcium in the bone, or osteoporosis, which is not only lack of calcium, but is also a higher risk for fractures. So a lady again, because we see that more often in ladies falling from her height and breaking a wrist, there's something wrong going on. She should not have broken her wrist. We would need to consider, is there any underlying osteoporosis? So when to worry about Alzheimer's disease? When we see benign but frequent oversights, when people are searching for names of familiar members of their family or people that they know, repeating and repeating the same question within a very short amount of time. And I did see this very commonly in the office. They could repeat the same question within 2 minutes. But at the beginning, it's not that. It's that they ask a question, they get an answer, and 10 minutes later, it starts again. When there is a family history, mainly a first-degree member, so father, mother, or sister, or brother, or many second-degree members, uncles and aunts and cousins, then maybe we should be looking into it. Hesitation in the words that are being chosen. So this may also be a sign that we should be looking into it. And also when we see deficits that are noticed and accompanied by frequent denials. So the patient made a mistake, either got lost, and then is trying to find all sorts of reasons to say, no, it's not his fault, just not the road that he usually takes, and he got lost. But they're always looking for causes to explain their deficits. And they won't admit what is going on. So to make it simple, there are two ways of looking at the different stages of dementia. Well, the first stage is it appears very, very gradually. So this may be at the beginning a transition between the MCI we talked about and the dementia itself. Then there is a progressive deterioration and loss of autonomy, and it gets to a point where the patient is completely dependent and completely inactive. This is too easy, so we'll be also looking at it in another way. There are 7 stages for a cognitive deterioration. So it's a scale from number 1 to number 7. Number 1 is there's almost no deficit at all. Nobody could perceive it. The patient doesn't know about it, and the friends nor the family will have noticed anything. To a stage 7, where we see a very severe dementia, where the patient is completely dependent on others to carry on with his activities. So let me review with you the 6 other stages so that you know where maybe a friend or family member is standing. So stage 1, we said no cognitive decline. In stage 2, it's called very mild cognitive decline. There are subjective complaints of memory deficit. So the patient is feeling something is wrong, but they don't know exactly what's going on. They're forgetting where one has placed familiar objects, forgetting names well known to them. In clinical interviews that we may do, we could miss, depending on where they stand in stage 2, but we could miss this deficit. And definitely no objective deficit is seen socially or even at work for those who are still working or another job. In mild cognitive decline, so we went from very mild to mild, level number 3, patients got lost in places that were not familiar to him or to her. At work, people are noticing something is wrong and the performance goes down. Same thing within the family. People are starting to notice there's been a change. Patients is looking for words more and more often, and reading and retaining very little, having to start the page again and again, forgetting people that are presented to him, deficit in concentration. It becomes obvious at work and in socialization. The denials become more and more frequent, and patient becomes more anxious because, again, feeling that the deterioration is going on. In moderate cognitive decline, it becomes evident with the questionnaires that we'll do. The patient is forgetting details about his own history, like the university he went to or the college he went to, deficit with concentration and subtractions. So even doing very simple calculation becomes hard. Denials are increasing. The affect. So the way the patient is presenting himself is flat. There's less joy of life, what we call anhedonia. And also, patients is withdrawing from difficult tasks. It's too hard for him, so he just won't bother doing it and leave it to others. In moderately severe, the patient cannot stay by himself anymore. He needs the help of somebody else. He's forgetting very important segments of his life. The names also of people that he knew well. It may be the names of grandchildren, of colleagues at work, or the previous boss. He's more disoriented in time and places, and he has more and more difficulties with calculations and subtractions, going from 40 to 0, subtracting by numbers 4, 40, 36, 32, 28, and so on, becomes almost impossible, and also impossible to travel. The patient is not interested anymore and would be very difficult to bring along. Level number 6, patients are even forgetting the helping person that's been around for a long time. They do not recognize the present events, so you may question of the patient about what has been going on. Is there something going on in the world presently? And no, they can't recall. Having difficulties doing subtractions from 10 to 0, subtracting by levels of 1. Disoriented again and more in time, places, and persons. For the body, incontinences are starting, either urine at first and then stools, and you question them about this, and they don't even think that something is wrong with that. There are changes in personality, emotional changes. Patient may become even more anxious, even violent. And then they develop what is called a cognitive abula. Cognitive abula is patients have an idea of what they should be doing or some type of idea. Will get up from the chair, for example, to go and wash the dishes. And then once they are in the kitchen, they forgot already what they were going to do. So they come back not having done anything. And level 7, very severe, completely dependent. The body doesn't respond to the brain anymore. And also patients are most of the time bedridden. If not, they won't follow the advice because they don't retain the suggestions. So essentially, these are the stages of the cognitive deterioration. And it's not at the stages 6 or 7 that we should be doing something, is if we do, it's mainly at the beginning. So these are the different stages from 2 to 6, and we've discussed before 1 and 7. So this may be the most important slide of the presentation when we talk about what we can do to prevent Alzheimer's disease. Age. There's nothing we can do for age. As I always like to say, the best way of not dying young is to get older. So we just have to let it go and accept that we are aging and adapt ourselves, but that is something we don't control. For the genetics, we don't control it because when we are born, we have all our genetic markers. But we'll be reviewing that at length in a few slides, and we'll see when people would be vulnerable to a genetic gene that may predispose to Alzheimer's disease. Nutrition, the best diet or way of eating that we should be following is the Mediterranean diet that we will review in the next slide. The Mediterranean diet is pushing more whole wheat grains, multigrain products, nuts, fruits and vegetables, plenty of fruits and vegetables, fish, poultry, vegetable proteins like tofu, and trying to avoid as much as possible red meat and also sweets, and also trans fat should be avoided. So in the Mediterranean diet, we're talking about one meal of red meat a month. So that's not very common, and the size of the servings should be as little. So when we're talking about a steak, it should be the palm of your hand, not more than that. When we're talking about a piece of cheese, it should be the end of the thumb. So it's the cereals should be the hands, the cupped hands like this for the cereals. So be careful with the portions or the servings, because if somebody wants to lose weight, it's not with more exercise that they'll tend to lose weight. It's with cutting down the calories. So if I go for a walk, a brisk walk for an hour, and I burn 250 calories, well, that's exactly about the equivalent of a Tim Horton donut. So in order to burn the 250 calories, I would need to walk an hour of intermediate speed. So it's quite a bit of energy spent just for a donut. So it's the way we are eating that will make a difference. For those having high blood pressure, again, combined with the Mediterranean diet, we would advise to add up the DASH diet, D-A-S-H, which stands for Dietary Approach to Stop Hypertension. And we know that hypertension is involved with roughly with 40% of cases of heart disease and heart attacks, 40%. And when we talk about high blood pressure, we're talking about what the food we're eating, but also with salt. So for sodium, we should not be taking more than 2,300 milligrams of sodium per day. That's exactly 1 teaspoon. And just to give you an example, in 1 tablespoon of light soya sauce, there are 960 milligrams of sodium. So that's almost half of the sodium of the day in 1 tablespoon of soya sauce. So again, read the labels and know your numbers. As for intellectual stimulation, very significant. 4 kind of activities in intellectual stimulation. The first one would be creative activities. So painting, drawing, playing music, gardening would be creative activities. Second one would be to have social activities where we do, for example, volunteer work, or we get involved at the church or in your community. Another one would be doing some plays, or should be doing some training for our brain. So playing bridge or playing I'm looking for my English word, social games that we can do when we are counting and figuring out things would be also significant. And finally, educative work like what you're doing now, trying to learn things. So maybe going back to the university for one course or two, that would be helpful. Physical activity definitely also may be involved in the protection of our brain. And we're talking, if you are well enough and you start progressively, to do between 150 and 300 minutes of activity or exercise per week. Those who had the greatest gain were those who were not doing anything and started to do a bit of physical activity. They got the most significant gain. But it is even better if you do between 150 to 300 minutes of activities, intermediate intensity per week. After 300, very good, excellent to prevent cancers, but from the heart point of view or arterial point of view, may not make such a big difference. Just a few advice. If you're involved in physical activity, one thing that I would suggest is the following approach. First of all, why do I want to change the way I'm living? By starting to do some physical activity, what am I looking for? Why am I doing that? Second step is to find out, where am I now? What is my present condition? So at least you have a base to start with. The third step is to find out where you would like to go. What level would you like to reach? What is your goal? That would be the third step. The fourth step would be, what will I do when an obstacle arrives? Let's say that you start to go for a walk 6 times a week, and today there's freezing rain falling. So you've already planned another activity that could be done, so you won't just stay inside, not do anything. You have planned something in advance, and maybe with somebody else. As for the weather, unless very exceptional weather, exactly like freezing rain or extremely cold or extremely warm, choose the proper time of the day. And except for these exceptions, there's no bad weather. Just remember, there's only bad clothing. Get dressed appropriately. If it's raining during the summer, that's okay. Get dressed well and move, and you'll discover in the nature, or even in the city, or even at night, new things, new stimuli that will be interesting, and you will never regret coming back from a physical activity. You'll never regret it. As for the cardiovascular diseases, everything you will do to protect the arteries of your heart will be protecting the arteries of your brain and the arteries of your liver and your kidneys and so on. So be careful. The predisposing factors like diabetes that we'll be talking about, or high blood pressure, or cholesterol, or stress that are contributors should be dealt with to decrease our likelihood of developing arterial disease. Because when I hear somebody having had a heart attack, I'm always worried not only about the heart, but I'm worried about what may happen elsewhere in the body with arteries. And if it's in the brain, well, it may be a stroke. So it's not only a heart problem, it's an arterial problem. For the diabetes, so high blood glucose, type 1 people, usually young people do not produce insulin anymore. In older patients like us, we would still produce insulin, but not enough for our needs because the pancreas is failing in its capacity to produce enough insulin. And the major or the most important predisposing factor of type 2 diabetes is obesity, with abdominal obesity, because with the fat, especially around the abdomen, there is a resistance to the insulin, though the pancreas is producing always more and more and more insulin to overcome that resistance, and at some point cannot keep up with the production, and then the sugars will start to increase progressively, and that will eventually become a diabetic condition. So make sure the diabetes is under control. When it is not, it may cause inflammation in the brain, and inflammation in the brain from diabetes is called diabetes type 3, and it has a direct effect on our cognitive functioning. Sleep, we should be aiming ideally to 7 to 8 hours of sleep per night. The room should be completely quiet, dark, and cool. So forget about the very warm bath before going to bed. The body has to be refreshed, yes, but certainly not overheated. Be careful with screens and iPads before going to bed. No alcohol, no caffeine during the evenings. And if you have some pain, deal with the pain, get it treated, because if you wake up, well, you need to deal with this. Or if it's the bladder that is waking you up, well, start drinking liquids in the evening or later on at night so that you have a better night of sleep. Be very careful with sleeping pills. They may cause confusion, and they may be involved with falls. People getting up at night or during the day, and they fall. And again, they may break bones. Be careful also with drugs over the counter. They may not agree with your usual pills. And the statistics say that by the age of 70, about 40% of patients will take 10 different types of prescribed medication, 10 different family of prescribed medication, and about 25% will take 6 different types of family of medication. So there's a lot of prescription of medication, and sometimes one specialist doesn't know what the patient was taking before or the side effect he's had. So be careful. Your family doctor should be the policeman at the crossroads, advising you if they go together, and should be looking at your medication also, and your pharmacist, obviously the pharmacist. No smoking. Smoking is involved with chronic diseases of the lungs and may also be involved with arterial disease and heart disease. So it's not a good thing. It's very hard to quit also. Sex, well, it's not having sex that may predispose to Alzheimer's disease. It's just that it's more frequent in women than men, as we've mentioned. So 2 women for 1 man. Hearing loss may contribute also to Alzheimer's disease. People are not perceiving sounds properly. They don't understand what the others are saying. They don't grasp the meaning. They don't socialize as well. So if you think that you have a hearing loss, please get it checked, do an audiogram, get it checked. And if you need hearing aids, well, get them. And it may be not only helping you, but also helping your spouse who's been dealing with hearing problems. And finally, the microscope that you see is making sure that you have good lab results. If you have a lack of folic acid or a lack of B12, or the thyroid gland is not functioning properly, or that you have good kidney function, the sugar is okay, you're not anemic, and so on, get it checked and discuss it with your physician. If everything's fine, that's perfect. If not, it can be corrected or looked into. So that's the Mediterranean diet. So the base of the pyramid is, as we were saying, whole grains, pasta, beans, and whole grain bread. As for celiac disease, which may not function here, celiac disease is seen in wheat, is seen in l'orge. Comment on dit de l'orge en anglais? Orge is, anyway, we'll find it. El seigle et orge. There's two other cereals in which we find
barley,
celiac. Pardon?
Barley.
Barley is for orge, and the seigle is, I forgot. well, Anne-Sophie's looking at it. Rye, that's right. So rye, barley, and wheat contain the protein of celiac that people are allergic to. If you don't eat any of those and people develop the diarrhea, it's because most likely the food they were eating was contaminated. So for the diet, Mediterranean diet, vegetables and fruits, 7 to 10 per day. Dairy foods, eggs, and olive oil. There's a difference between a very low fatty diet and Mediterranean diet, because in a very low fatty diet, you won't find olive oil and you won't find much eggs. But in the Mediterranean diet, there are 4 eggs per week. So it's a different diet. The Mediterranean diet is the one for Alzheimer's disease. If you're asking me which type of cheese you should be eating, that's easy. If the cheese is good tasting, maybe you should not be eating that cheese because it's going to be too fatty. Good tasting, but too fatty. So fat content should be less than 10%. Fish, seafood, poultry, plenty per week, and avoiding red meat, as we said, once a month, and avoiding sweets and trans fat. What could be also helpful is eating some antioxidants. So these antioxidants are found in fruits and vegetables mainly. So usually during our daily activities, our cells are producing very highly oxygenated molecules that are called free radicals. And so when we are eating antioxidants, we are fighting up these very highly oxidative molecules that have been produced by our cells. So inflammation is a contributing factor that we see in the brain, that we see with patients in diabetes. And when we develop inflammation, it may be from small strokes, from a metabolic disorder. It will tend to increase the accumulation of some proteins that are involved with Alzheimer's disease. And 2 of these proteins that are very well known and that we can screen for with special scans done in research will be the amyloid beta proteins, and also the tau protein that you see. So the amyloid beta that you see will accumulate over the years and form a plaque. And these accumulate, and as I said, can be seen. And the places where you will find them in the brain will be explaining the neurological presentation of the patient. The tau protein will accumulate inside the neurons, so inside of the cells of the brain, and the communication between the cells is not functioning properly. The abnormal tau protein may spread from one neuron to the other, making the process an ongoing one with a vicious circle developing more and more, then from these developing an inflammation of the brain, and from the inflammation producing even more of these 2 proteins. And this is what we see in Alzheimer's disease. Those that have a genetic predisposition will tend to produce more of these amyloid and more of these tau proteins, and those who do not have a genetic predisposition have a lifestyle that makes it difficult to get rid of these proteins, a poor circulation of the brain, or one that is not efficient enough. So this is why the lifestyle comes into play. Just a picture to let you know what it looks like. So this is a plaque that has been accumulating of amyloid, and these are the microfilaments that we see of cells from the accumulation of tau protein. And that can be seen, as I said, in scans in nuclear medicine, where we inject a dye that is specifically made to be to stop over the amyloid plaque, or with the tau proteins, depending on which dye you will be using. So let's talk about genetics. In the brain, we have the formation, as we said, of proteins that may contribute to Alzheimer's disease. So there are 20 genes that may predispose us to Alzheimer's disease. Of these, 3 are important, and one is by far the most important. It's the apolipoprotein, or simply called ApoE. As you know, we have chromosomes, and the chromosomes contain our DNA. DNA is like the instruction manual. So everything on the DNA is contributing to the production of our proteins, and it is determining our characteristics. So we get a section of a gene from our father and a section of the gene from our mother. And this goes for all our characteristics: the color of your eyes, the color of your hair, the color of your skin, and so on. For Alzheimer's disease, the same thing. And there are 3 possibilities that can be transmitted: either the ApoE number 2, either number 3, or number 4. So you get a combination. So it may be any of these 6 combinations, knowing that number 2 will diminish the likelihood of developing Alzheimer's disease. Number 3 will have a neutral effect. So a copy number 3 and number 3 will both have a neutral effect. And copy number 4 will increase the likelihood of developing Alzheimer's disease. So ApoE2 is infrequent. We don't have any statistics really for ApoE2. As for ApoE3, so somebody who would have the 2 copies of ApoE, that would be 3, which is the most common presentation. The likelihood of having Alzheimer's disease by the age of 85 would be 10 to 15%. If somebody has ApoE3, ApoE4, the likelihood of developing Alzheimer's disease by the age of 85 would be 20 to 25%. And somebody being ApoE4 will have a chance of about 50% of developing Alzheimer's disease. So if that patient, ApoE4, would have a very good lifestyle, doesn't mean that they won't develop Alzheimer's disease, but the likelihood is definitely decreased. About 25% of the population has one gene that is ApoE4, and about 1% of the population will have ApoE4. But once this is known, of those having Alzheimer's disease, 20% of those will be ApoE4. So even if there's only 1% of the population, it's 20% of those with Alzheimer's disease that will be ApoE4. And at the memory clinic, we can test within roughly an hour and a few minutes for the genetic profile. It's tested in the saliva. It's free of charge. And you would be able to learn if you are, which gene you're having. And we usually recommend patients, if they want to be checked, those who are starting to feel that they have a memory deficit, those who were told by their family members or friends that they may have memory deficit, or those with a strong family history, either first-degree member of the family or several second-degree member of the family with memory deficits, well, maybe they should be checked. But if you are checked and we are told your genetic ApoE profile, well, you need to be able to live with the results. So before coming in, make sure that you're ready. Everybody would like to be ApoE2, but we need to accept that the final result may not be the one we wanted. So at the Memory Clinic, briefly, we do clinical research on Alzheimer's disease. We give information and we talk about prevention. We can do the genetic testing for the ApoE that is without any fee. You don't need to be referred by a physician. There is a clinic in Gatineau. There's one in Ottawa on Carling, not very far from the Royal Ottawa Hospital. And there's one that's being built in Montreal presently. We do a telephone pre-assessment. You may be, if you want, be involved in research programs, always on a voluntary basis, always. There's no fee associated with anything at the clinic, even for blood tests, scans, MRIs, nothing, everything is free. There's a summary assessment of the condition. We can send the results to your doctor if you want to, and only if you want to. And there's a clinical follow-up that we offer, and social and community support. What is a clinical trial? Well, it's involving human participants, and we are trying to develop or helping to develop a medication and a way to detect, treat, or prevent a disease. And again, it's always on a voluntary basis. If you think that you may say, well, I'll be a guinea pig, well, let's look at how it does work when we do studies. The first study that is done is fundamental research that's done in the laboratories. Then it's done on animals. Unfortunately or fortunately done in animals. You should know that all your medications were tested on animals. And then we go to a phase 1. Usually a phase 1 is to test the safety of the product. It would involve a few usually healthy patients, maybe 8 to 10 patients that are followed very, very closely. Then if everything is safe, we move to a phase 2 with the approval of Health Canada, a phase 2. The phase 2 is involving maybe 20, 30 patients with the disease, and it's to test the safety and efficiency of the efficacy of the medication. Then also, when everything is good and safe, we move to a phase 3, and we're checking safety, efficacy, and making sure it's harmless. And then if everything is safe, then we would get an approval, or it would get an approval, and then it would be available in all the drugstores in Canada. If a medication has been prescribed for one particular purpose, and the company would like to use it for another purpose, but it's presently available in all the drugstores in Canada, well, for that new purpose, we go back to a phase 3. And we start from scratch on phase 3, though, to look for a new indication for the medication. So as for the present medication in Canada, there's no cure for Alzheimer's disease right now, and there's nothing that is available from the drugstore to cure or to slow the progression of the disease. The medications that are available through OIP or through the RAMQ are available, but it's not to get to the base of the problem, it's to treat the symptoms. And it may not work on everybody. It may work for a short period, a few months to a year or 2 years. with some side effects, but it's the only thing we have available presently for the population in general. And as I said, it only works for a short time, and no new treatment has been approved since 2005 in Canada. So the medications that we see that are free and available through the drugstore, the donepezil, the rivastigmine, or the galantamine, or the memantine, are all aiming at the symptoms and not the disease itself. So there are presently 143 agents that are being studied around the world for Alzheimer's disease in about roughly 172 trials. And at the clinic, we're doing presently roughly 10 studies. So how does your involvement in a clinical trial would work? Well, as we said, it's free, confidential services. We get your medical history and overview of medication, making sure that it does agree with the medication that could be used. And we do cognitive assessments that Anne-Sophie will be talking about very shortly. It's at the beginning, if the patient is interested, we'll try to find the study that is the most appropriate for the condition of the patient. We'll have a first information meeting when we just discuss the study. Nothing is signed. Patient is going back with the documents at home, having the chance to talk to their spouse or to their children, their family, their friends. Then coming back if they are interested to sign the consent, making sure that the patient, even if the patient is interested, can be fit in, that we don't find anything that would be preventing the patient from entering the study. Then there's always a placebo involved in studies. Obviously, any serious study has the implication of a placebo. Sometimes it's one real medication for one placebo. Sometimes it's 3 medication for one placebo. We cannot do without a placebo. And we offer a post-study follow-up also once everything has been completed. The study may last 6 months, may last 3 years, depending on exactly which study was chosen. During the follow-up that we do cognitive assessments before, during, and after, physical and neurological examinations, blood work, MRIs, PET scan, and nuclear medicine. Again, this is all free. We may do lumbar puncture in some studies if the patient is agreeing. If not, we don't go there. And other examinations may be required, like, for example, ECG or EEGs that could be done. So I'll let Anne-Sophie explain what she's doing, a few cognitive tests that are helping us to find out what is going on, how severe the cognitive impairment is. So I'll let Anne-Sophie go, and I'll come back to you after. Qu'est-ce que tu veux?
Yes, hi. So hi, sorry. So as Dr. Moreau mentioned, I'm what we call a rater at the clinic. So a rater is an individual with a wide range of skills, and we mostly do cognitive skills. So we assess the patient and see if there's a cognitive decline and try to trend it. Some of the tests that we do, the first one is what we call the MOCA, so the Montreal Cognitive Assessment. It's looking at mainly memory, attention, language, abstraction, and obviously orientation. The scale is based on a total of 30, and depending on the result, we can see if there is cognitive impairment, and if so, at what level. Another scale that we do often is the MMSE, or the Mini Mental State Examination. It's an easier version of the first one. It's looking mainly at the same elements, starting with orientation. Then we go up to registration, so the memory and the recall, attention and calculation, language, and constructional practice, so the drawing that you can see on the right page. The score is also based on 30. We're trying to reach at least 28 to be on the normal range. Lower than that, we can see that there might be some cognitive impairments, and then we need to work a bit harder to know what are the causes of those impairments. So those two tests are done at the initial visit. So the first time like you come in the clinic, those tests are being done. And then if a study is proposed to you, there's different tests that are going to be done along the way. The first one is what we call the clinical dementia rating scale. It's looking mainly at dementia and how the person is doing on a daily basis, so day-to-day life. We also try to assess if there are any symptoms of depression. We have different cognitive skills looking at mainly just the memory side of it. So reading a story and asking back in 20 minutes, how much of the story does the patient recall, and much more. So those are the tests that we do at the beginning and during a study. It always differs from one study to the other, but those are the main ones.
So before I give you the final conclusion, there's a new program that is available. It's called LUCI, L-U-C-I. So you may find this with luci.ca. And it's a new application that is, in fact, helping you to favor good, healthy living habits to protect your cognitive health. So it will help to develop and keep good habits. And you may even have somebody that may be accompanying you, and it's free. It's very well done. So Luci, if you're interested. So just to remember that Alzheimer's disease is a type of dementia caused by inflammation inside the brain with the accumulation of proteins, the amyloid beta and the tau protein. There are roughly 76,000 new cases annually in Canada, and it's increasing. The incidence is increasing. One of the best way to try to prevent Alzheimer's disease is to take care of ourselves and have good living habits and to intervene early. It's not when we are at stage 7 or 6 that something should be done. It may be more at stages number 2 and 3 and 4. So again, taking care of yourself. The memory clinic is there for you if you are interested, and knowing that you don't need to be referred, there's no cost, and we can also do the genetic testing at no cost if you are interested. So thank you. We're ready to take questions, and Sophie's ready to answer some chat questions if you have some.
Maybe Dr. Moreau, you wanted to kind of remove the presentation on the screen, then we'll be able to see people. So, by the way, just my name is André Thibierge. I'm the director of the branch, the Outaouais branch. I take Michael had to leave, so I will kind of with Anne-Sophie help, and Mr. Moreau will kind of direct the circulation for the questions. As Dr. Moreau mentioned, you can send your question to the chat through the Q&A, the chat function, or you can raise your hand and ask for question live. So, Mary Graziano asked for a question, I guess. On vous écoute. We're listening to you. We have to remove your to open your microphone.
Oui, je l'ai. Mais je l'ai pas tout passé.
Okay, I guess that was a false alert.
I can answer that question. There was one question about.
There's one in the meeting chat. And if you want to read it, or
about somebody who has a mother in a CHSLD?
Yeah.
Yes.
Okay. Yes. First of all, it is very difficult and you need to be very patient. You most likely know your mother very well, which may be your most important tool dealing with your mother. So go with her, talking about things that she knows. What is going on today has no importance. What she knows, she remembers, is the most important. And always try to be very optimistic. Do you remember when Dad used to say this or this, and we used to have fun, and that type of thing? When you talk to your mother, make sure that the environment is very, very quiet. There's no stimulation around. Nobody's shouting around. There's not a lot of people passing by. So maybe in the room, maybe in the room, that's okay. Maybe in the room, and if she doesn't understand, maybe language is not the perfect way of dealing with your mother. Use your hands with gestures and try to get her attention. And sometimes you don't get anywhere one day or at that time. Just come back. Maybe there's something going on. Maybe she's hungry. Maybe she's tired. And if something is really going on, there might, if she's more confused than usual, maybe there's something else. Maybe she has a bladder infection or something is not right in her blood. Maybe the sodium is too low or the calcium is too high, but if it does persist, it should be looked at. But approaching a patient with Alzheimer's disease is tough and you need to be very patient.
Okay, thank you, Dr. Moreau. Is there anybody that has a question? In the meantime, I just want to remind you there's a link that we'll just put, that Leanne just put on the chat, is the an appreciation survey. Just appreciation, very short, 1-2 minutes to complete and to provide us with any suggestion or feedback on the today's presentation. Any other questions? Any?
Yes, there is a Q&A from Rondell Russell. It's called, the question is BAN 2401 nearing approval by Health Canada?
Not this one. There are some that are about to be approved. Similar way of working. So it's an immunotherapy, but we're not there yet. So we don't have any sign that this will be approved shortly. Some other medication some have been approved in the States, and we're doing one on that has been approved by the States. Health Canada wanted more studies to be done, and we've been doing that. So something should be approved maybe early 2024, maybe in spring, and we may be giving the treatment. So it all depends on Health Canada.
Okay, last chance for question or anything you would like to raise to Dr. Moreau and to Anne-Sophie. Did someone talk? I guess no. So Ben, if there's no more further questions, so I would like, in the name of the National Association of Federal Retiree, to thank Dr. Moreau and thank Anne-Sophie, Mrs. Terrien, for this great presentation. Personally, I learned a lot. 2 years ago, I was involved with someone near me and my family that had dementia, and so I learned a lot how it worked, and especially the prevention. Prevention is so important. Then I guess we're starting well, and we'll try to do better. So thank you again, Dr. Moreau and Madame Terrien. And so just a last reminder to fill the survey, and then I wish you a good, excellent end of day. Thank you, everybody.
Thank you for your time. Have a nice afternoon. Bye-bye.